Good morning, everyone. Thank you, or good afternoon. Thank you so much for joining us in session 2 of the Upgrade Oncology Pathology series, co-hosted by Project Pink Blue, ASCP, and a host of other partners. We're very excited for today's session, but before we do that, we're going to have Gloria just talk to you for just a minute or two because we did not have her on Tuesday. Gloria, go ahead.
Okay, thank you very much, Dr. Dan. And thank you so much, Joanna, for agreeing to take on today's training. Thank you so much to all the participants that have joined this training. As you are aware, this is a training from Project Pink Blue, being funded by Art Foundation Nigeria in partnership with American Society of Clinical Pathology, Bioventures for Global Health, Federal Ministry of Health Nigeria, and every other partner that's contributed in one way or another. And this is our key program in the Upgrade Oncology program this year. And our focus is to train pathologists to ensure accurate diagnosis in Nigeria. You will all agree that we have a lot of late diagnosis, a lot of inaccurate diagnosis, and this is our own way of trying to contribute to accurate diagnosis. So a very big thank you to all of you who have joined today. This meeting is going to continue for the next 6 weeks, and we hope that you join each of the trainings, and we hope to see that we're able to make a lot of impact in the work that you do. And we hope that you step down whatever training you have acquired in the course of these 6 weeks, and that is the only way we can ensure sustainability. So thank you very much, and I'm giving it back to Dr. Dan to take it up from here. Thank you so much, Dr. Dan.
Thank you so much, Gloria. I really appreciate those kind words and mentioning all of our supporting partners and hosts. So today we have 2 speakers. Very excited. Dr. Joanna Conant is a physician from University of Vermont. She's an assistant professor in pathology and laboratory medicine, and her expertise is in hematopathology and molecular diagnostics. And she's going to actually start the session today in a minute or two. And then hopefully she's going to be followed by Dr. Steve Kusick from Phenopath in Seattle, who's going to talk about flow cytometry. These were originally ordered in the opposite direction, but Dr. Kusick has not been able to join yet, so we're hoping to get him to join for the second hour. So with that, I will turn it over to Dr. Conant, and do remember, if you have questions, please put those in the Q&A. There's a little box at the bottom where you can ask questions, and Dr. Conant will answer your questions at the end. If you have a technical problem, you can use the chat at the bottom to let us know what you're having issues technically. If you can't hear Joanna or something is wrong with the slides, please let us know there. But if you have a content question, please put that in the Q&A. And with that, I will turn it over to you, Joanna.
It would help if I unmuted.
There you go.
Thank you, Dan and Gloria, and to the ASCP for inviting me to join you all today. I guess in the afternoon for you. I'm really excited to be able to share some of my knowledge and expertise. Now, molecular testing in hematologic malignancies is a very, very broad topic. So I wanted to try and narrow it down a little bit and talk specifically about clinical applications of next generation sequencing, specifically in myeloid malignancies, because that is where we do a lot, and the bulk of a lot of our molecular testing on a day-to-day basis. I'm trying to be cognizant of bandwidth things as well, so I'm going to turn off my video while we go through the presentation, just hopefully so that the slides will load a little bit faster for you as well. Okay, so let's get started. So today I'm going to provide just a brief overview of next generation sequencing testing with the methodology and applications of using DNA versus RNA and what those may be used for specifically. Then I'm going to spend the bulk of my time really focusing on more of the clinical aspects of it. So we'll go through 3 different cases and go through how we can use molecular testing to help with diagnosis, prognosis, and therapeutics of a variety of myeloid malignancies. So first, we're going to go over kind of a high-level, big overview of next-generation testing and how this works to put it into perspective. So this is a simplified overview of NGS testing. We do it on the Illumina platform here in Vermont, but the principles function very similarly across different platforms. So first, we extract genomic DNA, and we break it up into fragments. We then undergo library preparation, in which adapter sequences are added onto the ends of the fragments. We then target our gene regions of interest and then attach or hybridize these fragments to the surface of our flow cell. The fragments that are bound to the flow cell are complementary to the adapters that are added to our gene fragments of interest. These fragments then undergo PCR amplification to make lots of copies of our fragments of interest in a process that's known as bridge amplification and cluster generation. The result then is a distinct clonal cluster for each fragment of DNA, here shown in different colors of blue, yellow, green, and red. And then we go on to the actual sequencing of this process. So the process occurs in a method known as sequencing by synthesis. So clusters are sequenced simultaneously in parallel, hence next generation sequencing is also known as massively paralleled sequencing. So the DNA templates are sequenced base by base using our 4 nucleotides, A, C, G, and T, which are fluorescently labeled and reversely terminated. So after each synthesis step where a base is incorporated, the clusters are excited by a laser, which causes the fluorescence of that last incorporated base. And each base has a different color of fluorescence. This fluorescent signal is then captured by a built-in camera that produces the images on a flow cell. And so this is an example of one of those flow cells where we've captured an image, and you can see that each of those individual dots represents a clonal cluster of a DNA fragment, and we could determine which base was incorporated based on the color. With that, what we do is then, now that we have the sequence, right, of all of these little clusters, we then take those reads and use software to be able to align them to the reference genome. Once all of our reads are aligned to our reference genome, we can then do variant calling, where we can determine whether or not there's a point mutation or a small insertion or a deletion or things like that compared to that reference genome. And so in this example, we are here in the JAK2 gene, and there's been a point mutation or a change from a G to a T. And this would correspond to the well-known JAK2 V617F variant that can be seen in a variety of myeloproliferative neoplasms, for example. So now we can do next generation sequencing on DNA, on RNA, or both. And they really have 2 different applications. So on the DNA side, we can look for small single nucleotide variants or point mutations. We can find small insertions and deletions. And then we can also see small duplications, such as our FLT3 internal tandem duplications and the KMT2A partial tandem duplication. One can also use DNA for copy number variations as well. So if we're looking at gains in the copy number of gains in the number of copies of a particular gene. Now on the RNA side, we use RNA analysis specifically for looking at gene fusions and potentially for expression as well. So for fusion calls, we need to use RNA because the fusions frequently occur within intronic regions of the genes. And so if we sequenced the resulting fusion DNA product where the introns are still present, those regions, those intronic regions, are essentially too big, and we're not really able to capture and sequence those particular areas. But if we use RNA, where those intronic regions have been spliced out and removed, we can now sequence across that fusion where one gene is fused to the other and detect fusions in this manner. And so what type of next generation sequencing application, what panel that you'd want to do would really depend on what kind of application you want. Are you looking for point mutations and insertions and deletions? You would want to stick with DNA. If you're looking for more fusions and translocations, then the RNA may be a better use of your resources. For the most part, I will say that DNA is by far, in a way, the most common and frequent use of next generation sequencing in the clinical laboratory. So that really summarizes the methodology and approach to NGS testing, just so that we have a high-level background overview of what NGS is capable of doing. And so now I'm really going to focus on some of the clinical applications to next generation sequence testing to apply and see how we can use NGS in real life in the clinical setting. So this is the first case I'd like you to think about as we go through this first series of questions. So we get a bone marrow biopsy on a 62-year-old patient who has a moderate macrocytic anemia and thrombocytopenia. There are no clinical explanations for the cytopenias after a thorough investigation. So there's no medication or toxic effect. There's no autoimmune disease, etc. On bone marrow examination, we see that there is mild dysplasia, so just a little bit. Karyotype chromosome analysis was normal. And then by NGS testing, we identified a pathogenic alteration in SRSF2. So the most likely diagnosis in this context is which of the following: CHIP, ICUS, CICUS, or MDS. Now, I know that that was alphabet soup. And these are concepts that can sometimes take a little bit of time to think about. CHIP is clonal hematopoiesis of indeterminate potential. ICUS is idiopathic cytopenia of undetermined significance. CICUS, clonal cytopenia of undetermined significance. And MDS, myelodysplastic syndrome. And the distinction between these four entities really comes down to the presence or the absence of these three following things: a peripheral blood cytopenia, clonality, usually as determined by finding a pathogenic alteration on next generation sequencing panel, and dysplasia, significant dysplasia. And we can use those three things to really help differentiate between these four entities. CHIP, or clonal hematopoiesis of indeterminate potential, is when there's a molecular abnormality that we pick up, but there's no dysplasia and there's no peripheral blood cytopenia. A lot of the times we aren't picking up patients that have CHIP because we're not really doing any molecular sequencing on patients that don't have peripheral blood cytopenias or any reason to say, go do a bone marrow. But conceptually, it's good to think about what CHIP is as a precursor to the other three that we'll talk about. Clonal hematopoiesis is a clonal population of stem or progenitor cells that result from the acquisition of myeloid cancer-associated somatic mutations. It's present in up to 10 to 20% of normal elderly individuals, those that are 70, 80 and older. And the number of mutations increases with age. Now, clonal hematopoiesis of indeterminate potential, or CHIP, is the identification of clonal hematopoiesis, so a somatic mutation, in the absence of peripheral blood cytopenias or identification of an underlying hematologic disorder. CHIP is analogous to monoclonal gammopathy of undetermined significance, MGUS, or say a monoclonal B-cell lymphocytosis, where it's a pre-neoplastic process with a small increase in risk of progression to an overt myeloid neoplasm at a rate of about 0.5 to 1% per year. And then something important to note is that the three most common CHIP mutations that we see are known as our DTA mutations, which stands for DNMT3A, TET2, and ASXL1. However, there are a lot of other genes that are involved. These are just the three most common ones. So back to this table, we've just talked about CHIP, where we find a molecular alteration, but there really is no peripheral blood cytopenia and there's no dysplasia. Now, the remaining 3 entities on this list, the thing that they have in common is that they all have a peripheral blood cytopenia, so whether it's an anemia, a neutropenia, or a thrombocytopenia. The distinction between these 3 is really dependent on the presence or the absence of finding a molecular abnormality and the presence or absence of morphologic dysplasia. Now, MDS typically has all 3. There's a cytopenia, there's a molecular abnormality identified, and significant dysplasia. CICUS is when you have a peripheral blood cytopenia and a molecular abnormality, but the amount of dysplasia falls short of a definitive diagnosis, morphologic diagnosis of MDS. And then ICUS is when you have that peripheral blood cytopenia, but following a thorough workup, you don't find any kind of evidence of dysplasia, evidence of MDS, and no clonal abnormalities identified. So as you can see, molecular testing, in addition to morphologic evaluation, is really critical to be able to differentiate between these 3 entities. So this is a schematic from our online version of the new 5th edition of the World Health Organization of the classification of hematologic malignancies. It provides a great approach to the evaluation of a patient with unexplained cytopenias. So first, one needs to exclude other secondary causes of the cytopenias, such as nutritional deficiencies, autoimmune disorders, medication or toxin effect, etc. At this point, what we would do is get a bone marrow examination and submit samples for evaluation. Now, if there's a morphologic diagnosis of a hematologic malignancy, whether it's acute myeloid leukemia or myelodysplastic syndrome, then you continue the workup for that. That at least has an explanation for why a patient may have peripheral blood cytopenias. But if you're looking at the bone marrow specimen and you can't make a definitive diagnosis of some sort of hematologic malignancy, then the next thing it would really do is molecular testing to really risk stratify between ICUS and CICUS. And the distinction between ICUS and CICUS is whether or not there is a presence of a molecular alteration found on next generation sequencing. So why do we care? Why do we need to differentiate between idiopathic cytopenia of undetermined significance and clonal cytopenia of undetermined significance? Well, it's important because individuals that have CICUS, where a mutation is identified, those patients have an increased risk of developing an overt myeloid neoplasm, as you can see here. In contrast, in non-clonal ICUS, those that have a cytopenia, but no mutation is identified, there's no known cause for the patient's peripheral blood cytopenias, they essentially don't have a significant increase in risk of developing a myeloid neoplasm over the baseline population. And thus, these patients don't necessarily need any kind of increased screening or follow-up. Additionally, within CICUS, the type of mutation also actually really matters. So studies have demonstrated that there is a subset of high-risk gene mutations, which is represented by that curve in green here, which places a patient at an even higher risk of developing a myeloid neoplasm, even over compared to those that have CICUS with other alterations. So the genes that places a patient into this high-risk CICUS category are the ones that are involved in the spliceosome complex, SF3B1, SRSF2, U2AF1, and ZRSR2, as well as our DTA mutations, remember, the 3 most common ones seen in CHIP, so DNMT3A, TET2, and ASXL1, with an additional mutation, so a DTA mutation plus 1 additional mutation or more. These folks are the ones who really have a higher risk of progressing to an overt myeloid neoplasm. Additionally, if we look at survival curves for these patients that are in that high-risk CICUS group, the ones that were in that green color on the prior slide, we see that the overall survival of these patients has considerable overlap with patients that have low-grade MDS, so overt myelodysplastic syndrome with the dysplasia, morphologic dysplasia. So clinically, patients that have high-risk CICUS behave very similarly to those with low-grade MDS. So if we go back to our case of our person with cytopenias, there's really not a whole lot of dysplasia on the bone marrow examination. So we can essentially exclude myelodysplastic syndrome there. Now, the identification of an SRSF2 alteration in this patient would mean that this patient most likely has clonal cytopenia of undetermined significance. There's a cytopenia. It falls short of a definitive diagnosis of MDS, but we found a molecular clonal alteration. Not only that, we can call it CICUS, but the SRSF2 alteration is one of those spliceosome genes in the list of the highly predictive group, right? And so this patient, because we detected an SRSF2 alteration, we would call them high-risk CICUS, and this patient would have an overall outcomes that are similar to low-risk MDS. So in summary, next-generation sequencing can be really important for the evaluation of unexplained cytopenias and is really becoming a very frequent reason that NGS is ordered. In the absence of a definitive diagnosis of a hematologic malignancy, it can really help risk stratify patients into ICUS versus CICUS. Now in ICUS, no clonal abnormality is identified, and these patients have really no increased risk of developing an overt myeloid malignancy. That's in contrast to CICUS, where a clonal abnormality is identified, and these patients have an increased risk for developing a myeloid malignancy in the future. And how much of an increased risk is really dependent on what genes are detected on that myeloid panel. Okay, so our next case, we'll take a look at another example. We now have a 75-year-old who sees an oncologist for persistent macrocytic anemia. Just like our prior case, we've excluded the nutritional deficiencies, the medications, the toxins, the infections, and so on and so forth. So the next step here would be to do a bone marrow biopsy. In this case, on the aspirate smears that we receive, we find that there is a relative erythroid hyperplasia with moderate dysplasia seen within the erythroid precursors. We have some nuclear to cytoplasmic asynchrony. We see some abnormal nuclear lobation, and we have some basophilic stippling as well. Megakaryocytes had a subset that were dysplastic as well, with these widely separated nuclear lobes. And overall, when we did a differential on this bone marrow aspirate, the blasts were not increased and accounted for approximately 1% of total cellularity. When we do an iron stain of the aspirate smear, we identified 20% ring sideroblasts. And these ring sideroblasts are sometimes really hard to capture on images, but this is a nice example of a ring sideroblast right here on the right. We then do a bone marrow biopsy and evaluate that, and it shows a hypercellular bone marrow. Remember, this patient is in their 70s. And it still shows that relative erythroid hyperplasia as seen on the aspirate smears. So overall, the findings are very similar to what we'd seen on the aspirate smears. So as a recap, we have a patient with persistent macrocytic anemia without a known underlying cause. We did a bone marrow biopsy that was performed. It was hypercellular with a relative erythroid hyperplasia, 1% myeloblasts, and dysplastic findings seen within the erythroid and megakaryocytic lineages, and an iron stain showed 20% ring sideroblasts. Now, I didn't show the flow cytometry plots here, but we did flow cytometry. We do them on all of our cases as well. And it showed no evidence of an abnormal B cell population, no abnormal T cell population, and no significant increase in blasts or plasma cells. So essentially a normal flow cytometry evaluation. So now this slide should start to look a little bit more familiar to you now. So in our patient, we've now demonstrated that they have a peripheral blood cytopenia and evidence of dysplasia. Now, the vast majority of cases of MDS harbor evidence of a molecular abnormality or clonality, whether it's a cytogenetic or a molecular one. And that is something that we want to do in all of our cases of suspected myelodysplastic syndrome. We would send samples for chromosome analysis and molecular testing. So I wanted to show you just a standard approach or workup to MDS and to classification. First, we look, right, to see whether or not there are any cytopenias, whether it's in the anemia, neutropenia, or thrombocytopenia. Then we ask, when we look at the bone marrow, is there dysplasia? In order to have something on the order of enough dysplasia to call it MDS, you'd want to see at least 10% of at least one lineage involved. And that could be either your erythroid lineage, your granulocytic lineage, or your megakaryocytes. So that's kind of where we are with this patient, right? Our patient has a cytopenia and there is dysplasia. Well, the next step then, as discussed on the previous page, is to demonstrate evidence of clonality. Again, the vast majority of MDS harbor some sort of abnormality that's detectable by chromosome analysis or molecular testing. And not only does identifying an abnormality aid in confirming our suspicion that this patient has MDS, it can actually help to classify the disease as well. So in the new 5th edition of the WHO classifications, we now have 3 distinct subtypes of MDS that are based on the identification of either a cytogenetic alteration, as in 5q deletion, or a molecular alteration, as in SF3B1 or TP53. The remaining subsets of MDS are then classified based on morphologic evaluation. So chromosome analysis and NGS testing is done on all of our patients with MDS, which really helps in that initial disease classification. Because our ancillary studies are so critical in classifying a wide number of diseases, my institution here in Vermont has implemented a standard method of bone marrow collection. And what it does is it ensures that we obtain all the sample types typically necessary to complete all of our ancillary studies. So first, we collect aspirate smears for morphology. Then we collect sample in sodium heparin, and we can use that for flow cytometry, as well as for cytogenetics, which may include chromosome analysis and or FISH. Then we collect sample in EDTA for molecular studies, such as NGS. So that's essentially from all of our aspirates, all of the additional testing that we can do. And then finally, go back in, get a bone marrow core biopsy for morphologic evaluation as well. So here in Vermont, all of the additional reflex testing that may be needed for a case is determined by the pathologist based on morphologic examination and flow cytometric results. And so this ensures that all appropriate and necessary testing is ordered for diagnostic, prognostic, and therapeutic purposes. So in our patient, a karyotype was performed and shows a normal female karyotype in all of the cells examined. So here, because of the normal karyotype, we can at least exclude one subtype of MDS, the MDS with low blasts and 5q deletion. We also order NGS and we do our myeloid panel. And on this patient, it came back with an isolated pathogenic alteration in SF3B1 at a variant allele frequency of 34%. So in fact, the identification of an SF3B1 alteration really helps to classify our patient's disease as MDS with low blasts and SF3B1 mutation. This particular subtype of MDS accounts for 15 to 20% of all MDS cases, so it's quite common. And listed here below are the diagnostic criteria for this particular subtype, which includes identification of an SF3B1 mutation above a variant allele fraction of 5%. Now, in the revised 4th edition of the WHO from 2016, The disease was classified as MDS with ring sideroblasts, and they had a requirement that you identify at least 15% ring sideroblasts. And this threshold dropped to 5% rings in the presence of an SF3B1 mutation. With the new WHO 5th edition, one can make the diagnosis of MDS with SF3B1 mutation in the absence of ring sideroblasts if you find that SF3B1 mutation. Now, this doesn't happen very often. Usually the SF3B1 mutation and the ring sideroblasts correlate quite well with one another. The 5th edition of the WHO does note that ring sideroblasts, again at that 15% threshold, can be used as a surrogate when molecular analysis is not available or possible. And the best way to classify that disease then would be MDS with low blasts and ring sideroblasts. MDS with low blasts and SF3B1 mutation has the best outcome among all of the MDS subtypes. In the 5th edition of the WHO, distinction between single lineage dysplasia versus multi-lineage dysplasia is really no longer needed, as studies are starting to show that there's really no significant impact on outcomes in this particular subtype. Of note, MDS with ring sideroblasts that are wild type for SF3B1, so they don't have the SF3B1 alteration, have a less favorable outcome in overall survival and leukemia-free survival compared to those that have a mutant SF3B1. And finally, the identification of other mutations in addition to SF3B1 may have an adverse impact, thus essentially negating that good prognosis. So I want to take a couple of minutes to look at risk stratification in just a little bit more detail. The International Prognostic Scoring System, or IPSS, has been the standard tool used to risk stratify MDS patients since its introduction in the 90s. The IPSS and then the subsequent revised IPSS, or IPSS-R, uses 3 prognostic indicators to really calculate a risk score. And those 3 things are type of chromosomal changes that are identified, the percentage of blasts in the bone marrow, and then the peripheral blood cytopenias. And based on this information, patients are stratified into 5 categories: very low, low, intermediate, high, and very high risk groups. And as you can see on this graph on the right, these do a pretty good job of stratifying patients. The International Working Group for the Prognosis of MDS have developed and validated an updated model known as the IPSS-M. This incorporates molecular information to improve risk stratification of patients with MDS. So with IPSS-M, patients are stratified into 6 groups instead of the previous versions that had 5. There's now a very low, low, moderate high, high, and very high. And as you can see, this model nicely stratifies patients with regards to leukemia-free survival and overall survival. And the IPSS-M is quickly becoming the go-to prognostic model for use in patients and in clinical trials. So here's a little bit more detail about the molecular component of the IPSS-M to put this into context. So in developing this model, a total of 152 genes were evaluated in a cohort of approximately 3,000 patients worldwide. When adjusting for age, sex, and type of MDS the patient had, it was discovered that there were 16 genes that were significantly associated with outcomes, and those are listed on the left column here. There were an additional 15 genes that also demonstrated adverse outcomes, and these are listed on in the right-hand column here. And these are also incorporated into the model. So in total, there are 31 genes that are included in the IPSS model, which have a significant impact on prognosis. So one can easily see why an NGS approach is needed to be able to capture and evaluate these genes. Now, as expected, the number of genetic abnormalities also correlates with disease severity. Not only which gene is identified, but how many are identified has an outcome it has an effect as well. Now in this graph on the right, SF3B1 is pulled out separately, and that's important to note. The favorable outcomes associated with SF3B1 alterations were confined to those that were isolated alterations without co-mutations in other genes or in cases that have a 5q deletion. And this isolated SF3B1 cohort is highlighted in purple, and they function just like those who essentially have no molecular alterations at all. So back to our case, we have a 75-year-old with anemia, 1% bone marrow blasts, a normal karyotype, and an isolated SF3B1 mutation. If we then go to this website, the mds-risk-model.com, this is where you can enter in all of this information and get a risk score. So this patient would fall into this low risk category that has an estimated leukemia-free survival of 5.9 years, an overall survival of 6 years, and a 1.7 risk transformation to AML in 1 year. So in summary, the criteria for making a diagnosis of MDS remain largely unchanged. However, molecular results are increasingly becoming incorporated into disease classification and in prognosis. Given the number of genes that are required for appropriate classification and risk stratification, a next generation sequencing approach plays a key role here and is something that we do in all of our cases of MDS. So I will now move on to our final case of this session. This is now a 77-year-old who presented to the ED for a 1-month history of easy bruising, worsening fatigue, some shortness of breath, and a new onset of night sweats and fevers. We have a CBC that was performed, and that shows a moderate macrocytic anemia, leukocytosis with 70% blasts, and thrombocytopenia. So here on the right is a representative image from the peripheral blood that we looked at that shows a prominent population of blasts in the background, or a prominent population of blasts. And in the background, some hint that there may be some dysplastic findings as well. The hypogranular neutrophil and perhaps a hypogranular platelet or a large platelet as well. These are samples from the bone marrow. Both the aspirate smears and the biopsy section demonstrate marked hypercellularity and a predominance of blasts in the sample. Briefly, I'm going to show some flow plots that show a prominent population of CD45 dim cells that are positive for CD34, highlighted in purple in the lower left. And then the blasts are positive for CD117, HLA-DR, CD33, CD13, and some CD38, all features, and we have additional things that support that these are all myeloblasts. So in summary, with the information that we have right now, we know that the patient has an acute myeloid leukemia. From here, we then look to cytogenetic and molecular information to completely characterize this patient's acute myeloid leukemia, particularly with respect to final classification, prognostic information, and potential therapeutic options as well. This is the WHO 5th edition classification of AML with recurrent genetic abnormalities. This list has grown since the revised 4th edition and will likely continue to grow with time. So we have our recurrent cytogenetic alterations such as acute promyelocytic leukemia with our PML-RARA fusion, our 821 translocation, our inversion 16 translocations, and others. We also have some alterations that are identified by molecular testing, including AML with NPM1 mutation, AML with CEBP alpha mutation, and others. And finally, there's a classification known as AML myelodysplasia related. AML-MR is an AML that harbors specific cytogenetic and molecular abnormalities that are associated with MDS, These can arise either de novo or following a known history of MDS or an MDS-MPN overlap syndrome. And the defining cytogenetic molecular alterations are listed on the right. So as you can see, molecular testing will continue to play a significant role in disease classification. The karyotype for this particular case shows a complex karyotype with multiple structural abnormalities. And NGS testing identified pathogenic variants in IDH2 and in SRSF2. So in this case, if we go back to that list of AMLs with recurrent genetic abnormalities, both our complex karyotype as well as identification of that SRSF2 alteration classifies this patient as having acute myeloid leukemia, myelodysplasia related. Now, this table is from the most recent version of the ELN and NCCN guidelines, which nicely integrates both chromosomal abnormalities and molecular alterations together for proper risk stratification of acute myeloid leukemias. These must be evaluated for proper risk stratification. So the molecular alterations that are included here include CEBP alpha, FLT3, NPM1, RONX1, ASXL1, and TP53, and others. As we continue to sequence more cases and more genes, this table will likely continue to grow. And again, perhaps the most effective way to evaluate for all of these genes is using an NGS platform. Now, in our patient, due to the presence of the complex karyotype, as well as that mutated SRSF2, the patient is placed into that poor or adverse risk category. Now, remember, we also identified a pathogenic IDH2 alteration. Isocitrate dehydrogenase 1 and 2, so IDH1 and IDH2, are genes that encode for enzymes that are involved in the tricarboxylic acid cycle, or the TCA cycle. Pathogenic alterations will lead to impaired enzyme activity that causes an increased production of an oncometabolite called 2-hydroxyglutarate. This increase in 2-hydroxyglutarate leads to DNA hypermethylation, aberrant gene expression, cell proliferation, and abnormal differentiation, and can drive the development of acute myeloid leukemia. Now, there is a targeted drug called enasidenib. It's an IDH2 inhibitor. So this is a drug that binds at the heterodimer interface of IDH2. And what it does is it forces that abnormal IDH2 protein to adopt a non-catalytic open conformation. And what it does when that happens is it inhibits its function. And so by inhibiting the function of that mutant IDH2, you get decreased levels of 2-hydroxyglutarate, and the affected cells then are able to differentiate, and you get that restoration of cellular differentiation. In the United States, the FDA has approved the use of enasidenib for relapse and refractory AML back in August of 2017. There are ongoing studies with positive results so far for using enasidenib in newly diagnosed AMLs, and our clinical colleagues are pretty optimistic that this will be FDA approved for the new diagnosis as opposed to just relapse and refractory AML. So in summary, I hope that I've been able to develop a picture just to show that NGS testing plays an important role in acute myeloid leukemia, specifically to aid in classification, prognostication, and treatment decisions. At this time, we're performing NGS testing at the initial diagnosis as well as relapse to determine whether or not there are prognostic outcomes and treatment considerations that should be considered. But then we're also starting to do a lot more testing when patients are in remission. And the reason why is to determine whether or not there's measurable residual disease and potentially identify individuals who may be at a higher risk of relapsing in the future. So in summary, molecular testing in general plays a critical role in hematologic malignancies across a broad spectrum of uses, including disease classification, prognosis, and therapeutics. And I have a couple of supporting examples here where molecular testing can aid in disease defining or disease supporting, prognostic markers, and therapeutic markers. So NGS is typically used in conjunction with cytogenetic techniques such as conventional karyotype and FISH analysis to establish a comprehensive genomic landscape. Now that there's an increasing number of genes that need to be evaluated, employing a massively parallel technique such as NGS has become the standard approach to be able to evaluate a large number of genes at one time, and thus making things a lot more efficient. But I do want to acknowledge that smaller panels still continue to have utility, as they frequently provide more rapid results and are comparatively inexpensive. And some examples may include a myeloproliferative panel that specifically looks for just JAK2, CALR, and MPL that can be done as a quick screen and evaluation in patients where there's a suspicion of a myeloproliferative neoplasm, or smaller, very targeted, rapid panels for AML that can provide quick results while the rest of the large NGS panel is being evaluated and run. And so with that, I will provide my list of references here that you can go and you can look at a later time. And I will now pause here as I think we've got some time for questions.
So I know
Hi, everybody.
Like you said, Carrie, I know that you're.
Thank you so much, Joanna. So let's do some questions. We have about 12 minutes before we will switch to Steve Kusik, who has joined. So if there are any questions, please put those in the Q&A. I'm not seeing any open questions at the moment. Steve, as you joined towards the end, did you have any questions that you wanted to ask Joanna about NGS and heme malignancies that might be illuminating for the audience?
And can you hear me? Am I?
We can hear you just
Okay,
fine.
perfect. Yeah, Joanna, in practice, what is your algorithm? What are people expecting of you, your oncologists? And you know, in my setting, working in a private lab, we have challenges with reimbursement, and for the folks in Nigeria who are not in the United States, who are listening, you know, whether we all know these tests are indicated, whether we actually get paid for doing them can be a challenge. What's been your experience, Joanna, up in Vermont, in terms of expectation and in terms of what you can actually get paid for?
Yeah, I think that's a really challenging spot. Reimbursement issues have always been something that we've had challenges with as well. It's getting better, I will say, and for the most part in myeloid malignancies, certainly when we have a patient that has MDS, bona fide MDS, and even now with that risk stratification of is this ICUS versus CICUS, we're seeing that those are becoming more widely reimbursed as well. Mm-hmm. So in the myeloid realm, and certainly AML as well, we're not having a hard time there quite as much. And in terms of expectations, so the ordering of these tests is now the responsibility of the pathologist. So the pathologists, our hematopathologists and our oncologists, we meet every 6 months or so and talk about our reflex algorithm. So if you make a diagnosis of MDS, we will do the following tests for further classification, risk stratification. We agree upon that. So when the clinician orders a bone marrow, they say bone marrow with reflex testing. And so for all of our MDS, AML, for the vast majority of our myeloid neoplasms, we are doing conventional karyotype plus our myeloid panel on all of these cases. And not having a ton of challenges with reimbursement when there's a definitive diagnosis of a myeloid neoplasm. I think the tricky part is when we fall short at that definitive diagnosis, where we can't say put a disease to that particular entity. Sometimes we have a trickier time with reimbursement issues.
And maybe just one other question. What I don't know if you mentioned, I mean, you mentioned a little bit about, measurable residual disease, or what used to be called minimal residual disease, and molecular testing to, to look for that, which in some cases can be more sensitive than flow cytometry, which I do a fair amount of. How much molecular MRD testing are you folks doing? Obviously, for something like BCR-ABL, for CML, or Philadelphia positive ALL, it's kind of standard of care. But how about some of these other entities? And what's the level of sensitivity you folks are looking for?
Yeah, so I think there's a big distinction between minimal residual disease and measurable residual disease, and an approach there. So our heme panel is validated down to a variant allele fraction of 2.5%. So certainly, right around hovering that range of morphologic remission, right? So what we're doing is looking to see, we don't do this all the time. It's often at the request of the clinician. Say if the clinician thinks that clinically this patient may be at a higher risk of relapse in the future for whatever reason, we have started doing some remission testing in these patients to see if we can identify residual molecular alterations at a variant allele fraction of 2.5, 5, 7% or so. Because if you still find that their residual alterations are there, these individuals, if it's not a clonal hematopoiesis alteration, right? Let's say if you find a residual NPM1 or SRSF2 or something like that, those patients are at a higher risk of developing a future myeloid malignancy. So at this point, NGS for MRD is really at the discretion of our clinical oncologists. And that's a different thing than, say, the really, really highly sensitive BCR-ABL1 for CML, or even, say, NPM1.
Right. Okay.
I do see one question in the Q&A. What is your advice regarding low resource settings in Africa where there's no molecular testing, no flow cytometry? Yeah, and I think that's really challenging. I think that, and hopefully some of this information will help drive the ability to be able to think about what is the best use and best case for bringing in some of this ancillary testing. Where are you going to get the biggest bang for your buck? And certainly, I think getting NGS testing up and running, each individual site and institution may not be able to do this, but is there some way that we can, say, have all of this testing and analysis done in one central location to be able to do this full evaluation and workup? Because as I've hopefully been able to demonstrate, is that molecular testing really is at where we need to be moving towards in order to fully characterize patients' diseases and do this ultimate classification, prognosis, and therapeutics as well. And then I see one other question here. What is the minimum molecular evaluation that a suspected MDS patient should do? Our patients make out-of-pocket payments for treatments. Yeah, and again, this is the hard part too. The nice thing about the molecular IPSS score is that you don't have to do all of the alterations in order to get a prognostic score. And so if we go back to, let me see if I can go back here, to our MDS IPSS score. There are a handful of genes that are on here that play a critical role. And I think one of the questions is, if you're going to do 6 or 7 genes, the cost effectiveness of running that additional panel to, say, 30 genes, what is the cost benefit ratio there? I don't know how much more it would be to do once you're doing 6. Once you get a whole panel set up for 30 genes, the cost shouldn't be that much more realistically. With that being said, one can still do a lot of risk stratification for MDS if you have access to conventional karyotype, because you can still go with this IPSS-R score here that just is based on bone marrow blasts, hemoglobin count, platelet count, absolute neutrophil count, and the cytogenetic risk group. So this works quite well for the risk stratification of MDS in the absence of having access to any kind of molecular testing.
Okay, thank you so much, Joanna. This has been really wonderful. I think we can now switch to Dr. Kusick. So Dr. Kusick, if you can please share your screen. Steve, you're muted.
Sorry about that.
That's okay.
Okay, screen share. Oh, here we go. Okay.
And then just test your down and up arrows for me on the keyboard, or however you want to move it. Yeah, you're good.
Yeah.
Okay, great.
Okay.
So thanks so much. So everyone, very excited to be joined by Dr. Steve Kusick, who's presenting this discussion on the introduction to clinical flow cytometry through the Burkitt's Lymphoma Fund for Africa, which is a charity that he has worked with for many, many years, including a very active program in Uganda on flow cytometry diagnostics, which I'm sure he's going to mention. He also serves as the medical director of Phenopath and is an affiliate faculty member of Pathology and Laboratory Medicine at the University of Washington. Go ahead, Dr. Kusick.
Okay, hello everybody, and appreciate the opportunity to talk to you about flow cytometry. I think the first question in the chat said that, at least where that person had come from, maybe flow cytometry is not available. And as Dr. Milner mentioned, there actually are two labs in Africa, one in Kampala and one in Eldoret in Western Kenya, where my collaborators and I have set up flow cytometry labs that are actually doing state-of-the-art 10-color flow cytometry and helping patients every day. And maybe we can discuss that at the end. Although for the bulk of my talk, I'm really just going to talk about what flow cytometry is and give a number of examples of normal and common abnormal flow findings in patients. So I'll talk a little bit about basics of flow cytometry. And then quite briefly, because there's a lot of technical aspects to consider, just like there is for molecular testing that Joanna just talked about, I'll talk about some of the technical considerations. And then probably most importantly, describe normal hematopoietic antigen expression as the key underpinning that allows us to identify abnormal antigen expression in the context of hematolymphoid malignancies. Okay, so basic. So this is actually a nice schematic drawing of a flow cytometer. And if one looks at the lower left, this column of shows basically individual particles or cells with different colored antibodies attached to them, and those different colors refer to the actual critical aspect of flow cytometry, which is that these specific, antigen associated antibodies are labeled with a fluorochrome or, a fluorescent dye that's activated by a laser and then fluoresces at a given wavelength so that we can actually detect that dye and in turn then detect the antigen that antibody conjugated to the dye recognizes. So that's really the key, is using the fluorescence properties of these dyes to identify antigen expression, which in turn allows us to identify the cell of origin expressing those antigens, and then hopefully whether it's benign or malignant. So there are four main parts of a typical flow cytometer. The first is the fluidic system. Actually, the the cell, the system allows a cell suspension, including these fluorescently labeled antibodies, to be propelled through the flow cytometer, which is the instrument that measures that fluorescence. The second part is the laser, which is a laser is just a light source of defined wavelength, and that activates these fluorochromes or fluorescent molecules, which then in turn fluoresce. And that fluorescence, which is, basically the form of light of various wavelengths, is then captured by the third part of the flow cytometer, which is the optical system. And the optical system, very cleverly using a series of these kind of square objects called dichroic mirrors, and then these rounder objects called bandpass filters, can actually partition the emitted fluorescent light into very narrowly defined ranges of wavelengths, and each of those defined ranges is then detected by a specific kind of detector, which can be of a few different types. And that detector detected fluorescent emission is then converted to electrical impulses, which are measured by the electronics, the fourth part of the system that's connected to a computer and appropriate software. And so this fluorescent emission then gets converted basically to electronic impulses, which then are shown, can be shown in 2 dimensions in routine flow cytometry data. And we'll, of course, be looking at a lot of that later on in the talk. So there are 2 kind of main types of measured parameters in flow cytometry. One is generic light scatter. So anytime you shine any light source on a particle, and that can be a human cell, or it could be bacteria, or it could be, plastic microspheres, tiny plastic balls. There are 2 main types of generic light scatter. One is called forward scatter, or forward angle light scatter, which is essentially a light scatter property proportional to particle size. So larger particles will have higher forward scatter. So in human cells, very small particles like resting lymphocytes will have low forward scatter, and potentially large cell malignancies will have high forward scatter. And then a second type of generic light scatter is side scatter, or right angle light scatter. And that's actually proportional to cytoplasmic complexity or granularity. So again, a small lymphocyte or resting lymphocyte with very little cytoplasm have very low side scatter, whereas a highly granular cell like an eosinophil will have quite high side scatter. And so forward and side scatter actually allow us to separate out the different components of hematopoiesis, either in the blood or the bone marrow, pretty well. And then there's true cell-associated fluorescence. And one of that actually also comes in 2 different types. One's actually intrinsic fluorescence, or what we call autofluorescence. So all human cells and animal cells, and probably really all cells, have certain intrinsic molecules, particularly complex ring structures that intrinsically fluoresce. And so all cells do have the ability to fluoresce, and a lot of that fluorescence is captured with a certain, or can be caused by a certain one of the lasers that's commonly used in flow cytometry. And we need to account for that when we measure fluorescence coming off cells. In particular, large cells often have quite a bit of autofluorescence. And then there's extrinsic fluorescence. The fluorescence is actually attributable to added reagents in our assays, and those can either be, for example, DNA binding dyes, so agents that will bind to the DNA itself, things like propydium iodide or DAPI, and those then fluoresce when excited by the laser, or most commonly the setting of flow cytometry bound fluorescently labeled antibodies that when specifically attached to their cognate antigen will fluoresce when the laser excites them. So, flow cytometry has some significant advantages versus histology. We can really get a lot of information about any type of particle, and we typically look at hematopoietic cells in the setting of hematopathology, which is what I practice, but one again can look at a whole variety of particles. We can make this very multi-parametric. So we look at 10 different antigens and then forward and side scatter. So a total of 12 parameters routinely in our lab in Seattle, and also in the 2 labs I partner with in Africa. It's very rapid. So for life-threatening diseases like acute myeloid leukemia, in particular acute promyelocytic leukemia, one can render a diagnosis within a few hours of getting the sample in the laboratory. It could be, it's highly quantitative, and in Africa there are a lot of laboratories still measuring, doing CD4 T cell counting in the context of HIV, and we can get good numbers in terms of terms of CD4 positive T cells. It really is highly reproducible because we all use standardized methodologies, and it can actually be very flexible. So, with a 10 color, 12 parameter assay, one can look at all kinds of different antigens in different cell populations for different applications. But flow does have disadvantages versus histology. So obviously, if we're looking at individual cells outside of a histologic context, we don't know about that histologic context. And along those lines, some hematopoietic tumors are really not easily detected, like Hodgkin cells can be detected by flow cytometry, but it's very difficult, and I would argue really requires kind of heroic efforts in the laboratory because these cells are so rare. We know that certain malignancies, we significantly underestimate the proportion of neoplastic cells among the total cell population assayed. In multiple myeloma, the neoplastic plasma cells are very commonly underestimated. We obviously require viable material, so at most, while we'll often evaluate samples that are even a week old, just if they're irreplaceable, really you basically have about 72 hours to try to generate all your testing on a sample. 72 hours from the time it's collected. So if the sample takes 24 to 48 hours to reach the lab because of transportation issues, then you really have a short time window. And again, it's very time sensitive. And although there's more and more expertise developing in flow, overall, my sense is among pathologists, there's much less expertise compared to routine histology and common techniques like immunohistochemistry. So there are a whole variety of clinical flow cytometry assays, and I'll abbreviate flow cytometry FC for the rest of this talk. And I'm really going to focus on the ones that we do most commonly in our laboratory, which is leukemia, lymphoma, and I would add myeloma analysis. Although in many of the labs in Africa, I think lymphocyte subset analysis is still quite common, although I know people are now moving more toward HIV viral load testing in that regard. So for leukemia, lymphoma, myeloma, or LLM analysis, there are some really unique aspects. So we're not just enumerating cells like we might be for CD4 positive T cells or CD34 positive stem cells in some stem cell transplant settings, but we're really looking for abnormal populations that have unknown phenotypes. And particularly if the patient population one serves tends to be elderly, you often will see multiple abnormal populations. So Joanna mentioned, CHIP and CCUS, and some of those, abnormalities have correlates in the world of lymphoid neoplasia, and certainly we see these small, potentially sort of malignant precursors all the time, whether it's an MGUS or a monoclonal B lymphocytosis, et cetera. So knowing how to interpret those, and that really gets it at point 3, knowing what's clinically significant and what might not be becomes important to the pathologist interpreting the data. And then, adding molecular testing can be very helpful in terms of trying to figure out, prognostically which of these pre-malignant entities may progress. So this is a very complex slide that one certainly can look at after my talk, but it just kind of lists the common antigens that we look at in leukemia, lymphoma, and myeloma analysis by the indication. So the antigens are listed across the top of this very complex chart, kind of by cell lineage. B lymphoid antigens are grouped on the left, then T lymphoid antigens, myeloid antigens, and plasmacytic antigens. And these are different indications for where one might want to measure those antigens. And this was actually about 15 years ago. There was a committee of flow cytometry experts, and I was on this committee that kind of decided which or achieve some sort of consensus as which antigens one wanted to look at when one tested different indications. And I can refer you to that table at your leisure. So technical considerations. So getting back to our schematic flow cytometer, and again, this will be the technical people in the lab tend to work on this, but as a physician, if you're the laboratory director, of course, one should be familiar with this. So the fluidic system, there are some instrument settings that one needs to optimize, and we do this, of course, before we deploy the instrument in clinical practice. So the aspiration rate, there's actually the fluid, and flow cytometry is really based on, again, evaluating these cells that are in suspension. That fluid is propelled through the cytometer at a specific rate, and that if one increases that rate, one can look at a very large number of cells, more quickly. And that's what we tend to do when we look for, low-level residual disease, minimal or measurable residual disease after a patient who's been treated for a certain malignancy. So one needs to figure out the rate. If one has multiple lasers, and anything above 5-color flow cytometry will use at least 2 or more lasers. We routinely use 3 lasers in our 10-color methodology, and that's what's actually being used in Africa in the labs I collaborate with. Each laser will fire at a slightly different time, and that laser delay is actually critical for the optical system and the electronic system to understand or to figure out what specific fluorochrome they're measuring, because different fluorochromes are excited by different lasers. And that's really what allows us to get to so many colors, the fact that these lasers fire at different times. And then optical filters need to be chosen that really partition the emitted light from these lasers or from the fluorescence as specifically as possible. And then we need thresholds or levels of fluorescence below which we will not even measure the cell. That keeps the data files a little smaller, so we won't measure too many red cells or debris in the sample. Detector voltages have to influence really the signal to noise ratio. So what we can measure is true fluorescence that reflects an antigen being expressed, and what's just noise that's background. And then there's the issue of compensation. And compensation is very important, and a lot of people, it creates a certain amount of anxiety in flow users doing these complex multicolor assays. So I'll try to go through it briefly, because it does, even as flow cytometry analysts, such as myself and hematopathologists in the audience maybe, it does influence how we look at flow data in terms of whether we think it's believable or could be artifactual. So we talked about fluorescence of these molecular fluorescent tags or fluorochromes being really the critical physical feature that allows flow cytometry to even work. And so if this was really a nice paper, it's very old now, but it was a critical paper in terms of those of us who dove into high parameter flow testing 20 years ago or so. But any fluorochrome has 2 different spectra that are really characteristic of it. And the one spectra is called the excitation spectra, which is shown to the left of each of these pairs of kind of Gaussian curves. So if we look at something called cascade yellow, for example, the excitation spectra is shown on the left, and this straight line, this vertical line, is actually the laser exciting that fluorochrome. So at these different wavelengths, the cascade yellow may be variably well excited, and it turns out the wavelength we're using for this particular fluorochrome, a 405 nanometer laser, is really close to its maximum excitation. So that's going to impart the most energy to this fluorochrome. and then allow it, if this is conjugated to an antibody that's on a cell, allow it to give the most fluorescence. And then the second characteristic of each fluorochrome is its emission spectra, and that's shown in the dark kind of Gaussian, or the more heavily colored Gaussian curve here. And again, these are the different wavelengths over which emitted light from that fluorochrome is dispersed. And we can see these shaded areas are the filters, what we call bandpass filters, that collect that light. So we want to use filters that are centered around the maximum emission point of emission, wavelength of emission for each of these fluorochromes. Now, the reason we need to compensate or adjust for the emission of these different fluorochromes, as you can see that let's look at FTSE PE, PE Sci 5, PE Sci 5.5, PE Sci 7. These 5 fluorochromes are all actually excited by the same laser. And you see their excitation spectra, many of them are pretty lined up and well excited by this laser. And here are their different emission spectra. And you can see that these emission spectra, being Gaussian curves, have a fair amount of overlap. For example, FTSE and PE, and then PE Sci 5 and PE Sci 5.5. There's quite a bit of overlap, and the bandpass filters do a pretty good job separating out the emission. But this overlap means that some of the fluorescence, say, measured from a PE Sci 5.5 actually comes from PE Sci 5, because you can see there's some overlap of that Gaussian curve with this one, as well as from PE Sci 7. So that spectral overlap requires us to compensate for that. So, and I'll show in the next slide what that looks like in practice. When we set up an assay, we also have to think about fluorochrome intensity. So these different fluorescent dyes have different, some are brighter than others. So often the very bright dyes, like something called brilliant violet 421 or PE phycoerythrin, we may want to use those dyes or conjugate those dyes to antibodies that recognize fairly dimly expressed antigens that are expressed at fairly low level but can still be very important. Whereas the dimmer dyes like PER-CP or APC-H7, we may use for more highly expressed proteins, because we don't need the dyes to be so bright. So this is just showing one example of proper and improper compensation. So this is just fluorescent data from normal T cells in an assay. And these T cells in this particular sample should not express the antigen CD10, but they should express the antigen CD5. So you can see on this log scale here, there's high level CD5 fluorescence. And since what's well compensated data looks like this, where the population is kind of centered around a population that's negative for an antigen, is centered around a zero on the scale for looking at that antigen, again CD10 in this point. So that's well compensated data. Now, if the data are undercompensated, you'll get this diagonality where it looks like the CD5 positive T cells, which we know should be CD10 negative, actually are expressing some CD10. Alternatively, sometimes if you overcompensate, you can actually pull the population almost away from the zero into a more negative area. And so just really want to make the point that whenever you see diagonality of these cell populations of flow cytometry, that's a clue that the data may not be well compensated and you may be looking at artifact. Okay, there's a whole variety of QC and QA steps that need to happen at different frequencies, and I'm not going to go through these just for your reference, but there's daily QC we do, monthly QC, quarterly, semi-annual to annual, and that's all again QC on the testing instrument and our methodology, and then QA or quality assurance. Again, QC is quality control. QA is we really want to confirm for all possible cases that the flow correlates with the morphology. So, those of us hematopathologists will always make a slide from the flow sample and look at right stain that slide, look at it under the microscope in the context of doing the flow evaluation to make sure that something that looks like chronic lymphocytic leukemia by flow also looks like it on the slide, for example. And then we also, for our technical staff, we periodically confirm competence in a variety of ways, and we confirm competence of the whole laboratory by enrolling in proficiency testing programs. Okay, and the last technical consideration will be just what kind of samples can we use for flow cytometry? And really, as we mentioned, any cell suspension can be used, so it can be blood, bone marrow aspirate, body fluids, lavage fluids like bronchoalveolar lavages. We can even take solid tissues such as soft tissue biopsies or even bone marrow cores and disaggregate them in the lab. Add a tissue culture medium to the cells to keep them as viable as possible. And we can, as long as we make a cell suspension, we can do flow cytometry on that. So there are some requirements that we need to be pretty rigorous about. All samples should be adequately labeled, and inadequately labeled samples can be run, given that they're perishable, but not reported until adequate identifiers are obtained from the client or from the lab sending you the sample. We really like to see 2 or more patient identifiers on the tube containing the sample. For blood, bone marrow, or blood contaminated body fluids, anticoagulation is critical because clotted samples really are very difficult to work with. If one wants to do cytogenetics, then this sodium heparin is the mandatory anticoagulant in most labs. For tissues, we use a transport medium that's a tissue culture medium that's supplemented with nutrients for the cells. Cerebrospinal fluid really having no nutrients in it, one really needs to mix with an equal or greater volume of transport medium. And then other body fluids, usually there's enough nutrients in the fluid itself that they may not need to be supplemented. And then finally, we can consider a lot of factors and whether we should run a sample by flow cytometry. We talked about patient identifiers, cell count, how cellular the sample is, how old the sample is, what the cells look like. I think we always need to be cognizant of whether or not the sample is replaceable. Peripheral blood obviously is, so we might be less willing to use a week-old sample to do flow cytometry on blood, but certainly tissue biopsies are not. So we need to factor that in. And none of these consideration really dictates whether to perform flow. So in our lab is we run all samples, even if they're a week old, and if there are problems, we of course document that even in the top line of our flow reports, and we describe what the suboptimal nature of the sample might be. Okay, so let's get into normal hematopoiesis. And for each of the lineages, this is, there are a variety of references that show when different antigens are expressed for different lineages. And again, I won't go through these in any great detail, but one can start with the very earliest committed cell of any particular lineage all the way to the most mature cell, like for B cells, the early hematogones in the bone marrow, to the terminally differentiated B cell, which is a plasma cell. And these different antigens are expressed, to different extents at different points during maturation. So the pale red in this particular figure shows relatively low level expression, and the really deep red, almost maroon color, shows high level expression. So for example, plasma cells express very high levels of CD38, whereas only the most immature B cells express an antigen like TDT, terminal deoxynucleotide transferase, which is a marker of early B cells. But in evaluating flow cytometry and directing a lab, one needs to know all of this very intimately. And then this is just normal B cell maturation in the bone marrow, kind of an older figure, but frankly, this figure is completely appropriate today because these maturation patterns are invariant. And so one needs to really understand these completely in order to then evaluate bone marrow for immature B cell populations. as one might see in the setting of B-cell acute lymphoblastic leukemia. So, and then if one knows these very well, then one can contrast that normal B-cell development in the marrow with a case of BALL, where here the tumor cells are shown in black. And here's on the upper left, another way we can separate hematopoietic cells by CD45 versus side scatter, with the brightest CD45 positive cells being mature lymphocytes with low side scatter, and in this case, the faint green population being granulocytes, and then the blasts, the B lymphoblasts, being shown in black here with characteristic B lymphoblast associated antigens like CD34 and CD19, HLA-DR, low aberrant CD33, no kappa or lambda, and if we're going to look at peripheral B cells, whether it's in blood or in the tissues, we need to know what normal mature B cells look like. These are B cells in a normal or a benign lymph node. So if we look at the lymphocytes, and this is the software allows us to focus our attention on specific populations, we call that gating. So here, if we just gate or look at the lymphocytes, we can separate them into CD19 positive B cells and CD5 positive T cells. And these CD19 positive B cells, for those who are familiar with B cell development, once they leave the bone marrow and are mature, they will express one of the two different light chains, either kappa or lambda. And in a polytypic or polyclonal population of B cells, usually there's about a 1.5 to 1 ratio of kappa to lambda, just because the kappa light chain rearranges first in normal B cells. And that's shown here, a polytypic population. We call it polytypic because we're not really measuring clonality, which is more of a molecular assay, say by PCR. We're just measuring what type of light chain they express. And this is both kappa and lambda, hence the word polytypic. If it were only kappa or only lambda, i.e. light chain restriction, we call that monotypic. But again, monotypism, correlates very tightly with monoclonality. In lymph nodes, B cells often will separate into this higher CD20, CD10 positive germinal center or follicle center population, which again, because it's got both red and blue cells, is polytypic. And then these are the non-germinal center cells, which have lower CD20 and no CD10. And the germinal center B cells also express relatively high level, kind of intermediate level CD38, which is a normal feature. And then we can contrast that with a mature B cell non-Hodgkin lymphoma. I just show a follicular lymphoma case here. So in contrast to the polytypic nature of the kappa lambda expression, here the great majority of the cells are lambda expressing, and what we call lambda restricted. And when we kind of deconstruct this population in terms of CD20 and CD10, you can see that the lambda restricted cells have expressed higher level CD20 as well as CD10, so a germinal center population. We can look at their forward scatter characteristics. They're kind of medium size, a little bigger than the benign B cells in the background, but not really large. Again, cell size is measured by forward scatter, so a large B cell lymphoma would probably be a little higher on the forward scatter scale. And then we can look at BCL2 expression by these cells. This is actually intracellular BCL2, which is a feature of follicular lymphoma and tends to correlate with the chromosome 14/18 translocation. So that's again normal versus abnormal in the mature B cell setting. T lymphoid maturation, B lymphoid maturation occurs in the bone marrow. T lymphoid occurs in the thymus. And so, but again, has a very reproducible pattern in terms of antigen expressions, and those antigens are shown here with the more highly expressed antigens being darker blue. So TDT, a marker of immaturity in T cells as well as B cells, is high in the early stages and then gets turned off as these T cells mature. And again, there's a full range of maturation that occurs in the thymus, and then the mature T cell actually leaves the thymus and circulates, and then will take up residence in peripheral lymphoid tissue like lymph nodes. And we can see the antigens that get turned on earlier and later. Cell surface CD3 comes on fairly late, and it tends to be a marker of later thymocytes or mature T cells, as is the T cell receptors. And so if one looks at normal thymus, and we see this fairly commonly in the setting of either in children, thymic hyperplasia, so benign thymus and thymic hyperplasia in kids, or in thymomas in older adults. Right? Thymomas are actually a neoplasm of thymic epithelial cells, with the benign T cells just kind of being bystanders. But one can really tease out what normal maturation looks like. The black colored cells are common thymocytes. The lavender colored cells are even earlier, like prothymocytes, and then the green colored cells here are mature T cells. And this, I'll just draw your attention to this population here with dual CD4 and CD8 expression. That's the common thymocyte, so that it tends to form the bulk of majority of T cells, immature T cells in the thymus. But normal thymocytes have very reproducible, normal common thymocytes have very reproducible antigen expression that contrasts with TALL. And so this just, for example, CD2 and CD7 are both expressed on these T cells, normal immature T cells, whereas in this particular case of TALL, the neoplastic cells colored black express high level CD7 and no CD2, so that's aberrant. And these cells actually express no CD8 or CD4. So this is actually even a more immature T cell population than the common thymocyte. This is actually what we would call an early T cell precursor, ALL. And in the periphery, similarly, these are normal T cells in the periphery. The patterns would be identical for blood or a lymph node, for example. So they all, or the great majority of them, express both CD2 and CD7. They uniformly express CD3. The red colored cells are the CD4 positive T cells, and the light green colored cells are CD8 positive. And we always color normal cells the same across all the assays. So we always color CD4 positive T cells red in our lab, and CD8 positive T cells light green, because flow is really an exercise in complex pattern recognition. So coloring things the same makes it just a lot easier for all of us. And this is actually, so those are mature T cells. This is a normal mature T cells. This is a T cell non-Hodgkin lymphoma. So this black colored population expresses a lot of mature T cell antigens like CD4, CD5, CD2 and CD7, but lacks surface CD3, which is a marker which is an aberrant feature, and a real common feature in flow cytometry of many malignancies is aberrant loss of antigens that the lineage normally expresses, or aberrant gain of non-lineage antigens. And here's low level CD10 expression. This is the case of angioimmunoblastic T cell lymphoma, where CD10 expression normally not on mature T cells, in most mature T cells, is common. And then finally, we can look at granulocytes, which have really a lot of different antigens that are expressed from that vary in their levels of expression, from the most immature forms, blasts or progenitors, as we call them, through maturing cells in the bone marrow, to then fully mature neutrophils. Some antigens that are highly expressed on neutrophils are CD15 and CD16, shown in very dark green. And then the progenitor markers, like Joanna mentioned, that one AML case, she showed CD34 and CD117 are the two key myeloid progenitor markers. But notice CD34 is not unique to myeloid cells. It's also the progenitor marker of B lymphocytes and T lymphocytes in the bone marrow and thymus, respectively. And then the other major myeloid population, besides granulocytes, are monocytes, and they also, we think of maybe somewhat fewer antigens that we tend to look at when we evaluate monocytes, but they do vary with the progression from the blasts or progenitors to mature monocytes. One of the really important antigens we look at in the flow lab is CD14. because immature monocytes, which are often markedly expressed in acute myelomonocytic and acute monocytic leukemias, or what used to be called M4s and M5s. Typically, most of those immature monocytes lack CD14, whereas it's really just the mature monocytes that have a lot of CD14. And so a more mature monocytic neoplasm like chronic myelomonocytic leukemia, those cells being more mature, would have more CD14 expression. And again, another figure that obviously I don't expect anybody to commit to memory, but just to show you the complexity of looking at myeloid maturation in a normal bone marrow and the patterns one needs to understand. This is just a normal bone marrow where we can separate the populations by CD45 versus side scatter into progenitors with lower CD45, mature lymphocytes with high CD45 and low side scatter, monocytes colored lavender with kind of intermediate side scatter, and then granulocytes, neutrophil series cells colored green, and eosinophils colored orange, with a general rule that, with the exception of erythroid cells, all other myeloid stem cell derived cells actually acquire higher levels of CD45 as they mature. And I'll just show one figure, CD34 versus CD38. The earliest progenitors express that antigen CD34, and the real early ones have very little or no CD38. These tend to harbor, this population includes the true stem cells. And then as these cells mature, but they acquire CD38. And then as they move to later myeloid cells that are past the blast or progenitor stage, they lose CD34. And so knowing these patterns is real important for then being able to look at flow data and decide what's the likelihood that this bone marrow is involved by a myeloid malignancy. Now, acute myeloid leukemias or any acute leukemias are easy to identify by virtue of just the very large number of abnormal progenitors or blasts. But in a case like this, which is a chronic myelomonocytic leukemia, the blast population was not particularly expanded. And we always color in the setting of looking at myeloid neoplasms, we typically color the blasts red so we can, again, easily recognize them. And there are multiple abnormalities between this sample and the normal one. For example, there's no aberrant CD56 on the progenitors in this normal marrow, where there's both CD56 and CD5 on most of the progenitors in this marrow. So when we add up all the number of abnormal features, that are 7 here, that really supports this being a malignancy, and that was confirmed by molecular data. So that's just a kind of a brief overview of comparing normal to abnormal. Now I'll just go through a few other common malignancies we can identify by flow cytometry, with a high degree of accuracy, even if we don't have, say, the tissue biopsy or the bone marrow biopsy in front of us, we can be quite common, although we will, of course, correlate this with at least the smears or cytospins we've made from the flow sample itself. So this, again, in all the following plots, the tumor cells will be colored black just to contrast against the white background. So this is a population of cells with a high CD45 and low side scatter shown here. And this in light green are the normal T cells in the sample. And this black colored population co-expresses CD19, a B cell antigen, and CD5, a T cell antigen, uniformly. It's lambda restricted. All the cells are lambda compared to kappa, and it's fairly low level in the spectrum of lambda expression you might see in a B cell malignancy. And the CD20 is also fairly low, as is the CD22, another B cell antigen. And these cells uniformly express CD23, don't express a protein called ZAP70, uniformly express a protein called CD200 with CD79B at low level. So this is a very typical case of chronic lymphocytic leukemia or CLL, where really the hallmark is co-expression of this B cell antigen CD19 with CD5. Another antigen, non-B cell antigen that's aberrantly co-expressed is CD43, and then CD200 and CD23 are very common. This is a case of Burkitt lymphoma, which of course we think of as an endemic disease in sub-Saharan Africa, in which folks from that part of the world who are listening in may see a fair amount of. We've actually only seen a few cases in the 2 labs I collaborate with for reasons that aren't entirely clear to me. But these cells are again colored black, so they actually express sort of characteristically, quite a bit lower CD45 than the normal mature lymphocytes, although not quite as low as you typically see in immature B cells or B lymphoblasts. They express CD19 without CD5. In this case, they're lambda restricted, so a surrogate for monoclonality. They express low CD10 and CD20. And importantly, compared to the normal B cells that are colored lavender here, which do express cytoplasmic BCL2 at sort of low intermediate level, Burkitt lymphoma cells, as we know, are negative for BCL2, which is one of the features that help define them. And this case was confirmed to be Burkitt lymphoma by FISH, showing the fluorescence in situ hybridization, showing the characteristic rearrangement of the MYC gene. This is hairy cell leukemia, which is actually a relatively common malignancy we see in middle-aged to elderly patients in our practice. And again, the cells are colored black. These cells typically have higher level CD19 and higher level CD20 than the normal B cells. In this case, they're restricted for kappa expression, only express kappa. They aberrantly express an antigen that most B cells do not express, called CD123. They do express another pan B cell antigen, HLA-DR. And what really is kind of the signature of this disease and makes it very easy to identify, even in the post-therapy setting, the context of minimal residual disease, is this unique co-expression of an antigen called CD103, CD25, high-level CD11C, and high-level CD22. Here's plasma cell myeloma, cells again colored black. Now, the way to look at plasma cells very effectively by flow is to use that antigen we know they highly express when we looked at B cells, and that's CD38. So CD38 is so highly expressed in plasma cells, and if one looks at antigen expression on a log scale, where every additional decade represents a 10-fold increase in the surface fluorescence associated with the antibody, which is a surrogate for the actual expression of surface protein, one could see we're almost in the 4th decade, so very high level expression. And if we look actually inside the plasma cells at cytoplasmic kappa and lambda, because most of the plasma cell light chains are inside and they're ultimately secreted in the context of immunoglobulin rather than put on their surface, but we can see that the plasma cells of interest are cytoplasmic lambda restricted. And in contrast to the normal plasma cells, they aberrantly lose an antigen called CD19. A subset will aberrantly express CD56 and actually aberrantly express CD20. Most plasma cells don't normally express CD20. And some other markers of aberrancy are one other common one is CD117 or c-KIT disease expressed at a low level. Flow, this case is a nice example of how some of the phenotypes we see by flow point strongly to a specific genotype. And so low CD20 on, or low to intermediate CD20 in the setting of a plasma cell neoplasm strongly points to the 1114 translocation and overexpression of cyclin D1 protein, which actually is the same translocation that characterizes the great majority of cases of mantle cell lymphoma. So not a unique translocation for myeloma, but one that's strongly indicated by CD20. And then finally, I just want to show the lower row here finally for these plasma cells in the setting of targeted therapy, which we're seeing more in the United States, for instance, and hopefully we'll see more and more of this in Africa as well moving forward. We actually need to be thoughtful about how we design these flow assays so that in the presence of a targeted therapy, such as an anti-CD38 antibody called daratumumab, which is used in the setting of multiple myeloma to kind of leverage that high CD38 expression to help kill the myeloma cells. If one looks at a patient who's been treated with daratumumab, there's absolutely no detectable CD38 with our assay, because the daratumumab may be blocking the ability of our diagnostic antibody to identify the CD38 on the cells, or it may be that the patient's actually selected a subclone that CD38 negative has been selected following therapy. And so we need to design the assays to include other plasma cell associated antigens like CD138 and to look for, to enable us to identify those cells, which we do here, and then we can look for the aberrant loss of CD19 and some of the other features. So just a few more cases to look at. This is anaplastic large cell lymphoma, ALK positive, and the hallmark of this lymphoma is high level expression of CD30, which we see here, sort of fourth decade fluorescence, and this is a negative control antibody labeled with a fluorochrome, same fluorochrome called PE or phycoerythrin, so we can see the high level CD30 and the high level CD25, another antigen. Here's another example of phenotype correlating with genotype. The ALK positive anaplastic large cell lymphomas characteristically express a myeloid antigen, a non-T lymphoid antigen, CD13, which these cells do, that give us really a strong clue that these are going to be ALK positive and therefore a relatively favorable prognosis, ALCL, which we did confirm in this case. And then there are other T cell antigens, some of which are expressed, some of which are aberrantly lost in this T cell malignancy. This is an NK cell, aggressive NK cell leukemia. So these are the third kind of lymphocyte. They're B cells, T cells, and natural killer cells. And we haven't gone through the features too much of NK cells, but they express high level CD56 typically, and they often lose NK cell associated antigens. The normal NK cells here are these light blue cells. So compared to these light blue cells, these cells aberrantly have lost CD7 while retaining CD2, and they have a variety of other antigens. But really the hallmark for diagnosing aggressive NK cell malignancies, whether leukemias or lymphomas, is to confirm that these cells are infected by Epstein-Barr virus or EBV, and we typically do that with in situ hybridization assay, a chromogenic in situ hybridization assay to the EBR1 RNA. And then just to finish up with two types of AML, acute myeloid leukemia. This is AML with the 821 translocation, so a good prognosis, AML that's associated with granulocytic differentiation. Here are the black colored myeloblasts, normal mature lymphocytes with high 45 and lower side scatter in dark blue, normal maturing granulocytes in green, and here are the blasts, and they express typical myeloid blast markers like CD34. In this case, they express CD38, CD117, CD13, high-level HLA-DR, and it's very characteristic of the 821 translocation to be associated with very low CD33, but with aberrant acquisition of low CD19, in this case, pretty high-level CD56. So again, this is a case where phenotype predicts genotype. One obviously needs to confirm genotype, which we did in this case by fluorescence in situ hybridization, but one could also confirm it with reverse transcription, PCR, RT-PCR, or standard cytogenetics or karyotyping. And then you finish up with probably the most urgent diagnosis in all of pathology, certainly the one that gets our blood pressure up in the flow cytometry lab, and that's acute promyelocytic leukemia, or AML, with the 15-17 translocation in the great majority of cases. We see this population here with fairly high side scatter, higher side scatter than we saw with the 821 translocation, and that reflects the hypergranularity of most cases of acute promyelocytic leukemia. Typically low, if any, CD34, typically low CD117, relatively high level CD33 with little or no HLA-DR. The typical features, typical low CD64, and then one feature that's very useful that we look for is actually high level expression of an antigen called CD9. which normal myeloid progenitors don't express. And this, again, we would sign a case out, like a case like this out, is consistent with acute promyelocytic leukemia, pending FISH confirmation. Again, we use fluorescence and situ hybridization to confirm that diagnosis within less than 24 hours. Okay, so to finish up, we talked about all the ability to look at a variety of multiple antigens simultaneously, and one needs to be aware that when one commits to looking at a lot of antigens, that leads to lots of pairwise combinations of fluorescence data that we can look at, since we take this multi-parametric data, and to enable us to wrap our brains around it, we'll project it as two-dimensional images. So 10 color, 12 parameter flow, there'll be 6 unique pairs of parameters that one can look at. And now if one moves to 13 color flow, as we're doing on one instrument in our laboratory, one then needs to be ready to look at 105 unique parameters. And we've also got a research instrument that's doing 21 color flow. So you can do the exponential math and figure out that's even more parameters. So not all of these two-dimensional projections are equally informative, but one needs to, and the human brain is amazing at pattern recognition once it gets trained in it, but one needs to recognize there's a lot of data to look at. So here are some references. Some of these were older, some more recent, and I would point you to the last 2 references. Here's the latest WHO Blue Book, the 4th edition. The 5th edition will be coming out this year sometime, and that's really still the best compendium where to look for immunophenotypic information on all the different malignancies. And then the International Clinical Cytometry Society, that I belong to for years, has got a number of great free resources that I would certainly refer anybody to as well. And with that, I'm happy to take any questions. And yeah, this is the Berkeley, the BLFA, that really helps sponsor a lot of the work we're doing in Africa with flow cytometry.
Thank you so much, Dr. Kusick. I think we only have one question. Have you answered the one question from Hamalu yet?
Yeah, I see the question. Yes, FNAs are, and that's a great question, particularly for low resource settings. But we certainly do see a lot of FNAs in our practice in Seattle here. Yeah, FNAs are terrific to use for flow cytometry. Because obviously they're easy to obtain with low morbidity. And I would encourage any lab that's doing flow on FNAs to always try to make either a right stain smear or cytocentrifuge preparation, if you have a cytocentrifuge where you can spin a cell suspension down onto a slide and stain, just to correlate with your flow. But certainly in the setting of Burkitt, in a patient who's maybe got very aggressive disease and one needs to make the diagnosis very quickly, that FNA may be actually preferable.
Yeah, and I would for the audience who there's some overlaps with our audience for this series and some of our other virtual education, one of which is our ASC, ASCP cytology echoes and cytology calls sessions. One of the things that we've heard about recently is ROSE, rapid on-site evaluation. And I think having the cytologist that collects the sample make a smear immediately and confirm, yeah, this is definitely a hematological lesion, and then send it for flow. That's super helpful for the flow lab to know what the cytologist saw on that smear, because then they can correlate it, as Steve said, with their cytospin, and then give a really helpful definitive answer. So absolutely, FNA is great. The other thing is that if you can FNA something, likely and you get a good smear of cells, then that can also inform you that it's probably going to be successful in flow cytometry. If you FNA a lymph node and it's big chunks of tumor, likely a metastatic solid lesion tumor, then you shouldn't you shouldn't flow that because it's not going to do well in the flow cytometer and is obviously not a hematological malignancy. So I think that rapid on-site evaluation, especially for lymph nodes or suspected lymph nodes that you might want to send for flow, is super helpful in saying, yeah, this is a single cell population that's smearing really well. We can definitely send this for flow versus these are big chunks of solid tumor. This is not a heme malignancy. Let's not waste the flow on it. So.
Yeah, no, it's a great point, Dan. And similarly, if a sample or an FNA is entirely necrotic, that's not something you want to send for flow. You certainly could do other testing potentially, but
yeah, absolutely. Well, thank you so much, Dr. Kusik and Dr. Conant, for this. We have one more question from Haruna. Thank you for this eloquent lecture. I practice in a facility without IHC, but just saw a true cut of liver and lymph node with likely diagnosis of Burkitt's. What is your take on this, the way forward?
Yeah, no, it's a great question. And, ideally, one would have a few immunostains. If it looks like a high grade lymphoma and it's behaving aggressively, and maybe there's the patient's having B symptoms, or the LDH, lactate dehydrogenase is elevated like you'd expect in that setting. Just confirming that it's B lineage with, say, CD20, which many institutions in Africa have, would that just so one could confirm that diagnosis to get the appropriate therapy would be ideal. I suppose if it's a 5-year-old boy with a jaw mass and it looks like Burkitt, we know that those can be occasionally misdiagnosed. Again, the CD20 on its own would be enough for me to justify starting the treatment of the patient for Burkitt. But and this is where flow could help you if one had that, really just one flow tube to look 10 years old. Yeah, and was this true cut of liver and lymph node? Likely, but there are mimics. I did a study with Suzanne McGoldrick from the Fred Hutchinson Cancer Center in Seattle, a retrospective review about 100 putative pediatric Burkitt lymphoma cases from the Uganda Cancer Institute from the 2000s, and 20% of them turned out not to be Burkitt when we did a pretty comprehensive IHC evaluation. So small blue round cell tumors can be something else. So ideally, at least one form of immunophenotyping, could be performed to confirm. So
yeah, well, I think one trick to keep in your toolkit, and you do need to think about it in advance, is if you have an aspirate and you do an air dried smear, as Steve mentioned earlier, or when you have a true cut, if you can do a touch prep of that by taking the biopsy and just touching it to the slide and then air drying it and game sustaining it, you often will get those little vacuoles in the cytoplasm of the Burkitt's lymphoma, which if you don't have IHC can be at least a clue that this may be Burkitt. So you can think about the treatment options there.
Yeah.
That is, you have to know in advance, and you do have to make those air dried smears and game sustain them. And it's not all Burkitt, not all tumors with those vacuoles are Burkitt's, but the vast majority are in the right clinical context. So that can be helpful.
Yeah, absolutely. And even, one non-heme malignancy that you'll see certainly in older, well, even in kids, the kind of neuroendocrine tumors, especially if they're relatively discohesive, the small blue round cell tumors, usually express very high level CD56, and because they're so discohesive, they can flow quite well. So in my practice in Seattle, I probably diagnose a small cell cancer about once a month.
Yeah,
small cell carcinoma by flow.
Yeah, absolutely. Well, thank you again so much, Dr. Kusik and Dr. Khanna. I think this has been really helpful and informative. I'm looking forward to the rest of the series. All of you will be receiving an updated email, which has our new landing page. That landing page is going to contain all of the registration links as well as links to all the recordings. So it's sort of one-stop shopping, and you'll see more details about that in the email. Until next week, thank you so much for joining us, and we look forward to seeing you all on Tuesday.
Thanks, everybody.
Thank you.